Before starting my talk, I would like to do a thing that is like related to the mental thing. First of all, you have been sitting for like hours. Yeah, we are all physios, right? Doesn't come out good. So if you will please rise. And going back to the mental thing, this is for one of my dearest friends and also my boss at Karolinska Institutet. She's not able to be here due to severe illness, but I promise her to give her power, to bring power back to Sweden. So I want all of us to bring power to Annette Heine, who is back in Sweden. And it's quite simple, so you don't have to have any, feel like, oh no, I'm gonna fail or something. It's just like very easy. You're just gonna, and then you're gonna scream, power, power! We do it again, okay? So now you know how it goes. Power! Thank you. I'm especially delighted to be in Switzerland, since I'm from Sweden, and I don't know what the thing is about Sweden, but they don't seem to get the trains go right. I commute every week between Gothenburg and Stockholm. It's a distance of 500 kilometers. As of yet, the train has never been on time. So I love being in Switzerland for several reasons. This is another reason. And after this session, you will be able to acknowledge catastrophizing thoughts and fear of movement as important factors in return to play. And you will also be able to identify reliable and valid measures to use in sports medicine. And you will also have some indication how you can work preventive with negative attitudes and beliefs in relation to pain. So, but when we talk about return to play and return to sports, who do we talk about? And who is it that is returning to the sport or the play? And what is the sport and the play? It can, of course, be related to high athletes or the elite athletes. Or it can be these people running in Gothenburg. It's a half marathon. We can't do more in Gothenburg. In Stockholm, they have the full thing. Or, of course, it can be these children playing soccer. Regardless of whom, pain is a complex phenomenon. And for all pain conditions, it comes with the affective, the cognitive, and the nociceptive or the sensory component. And that is important to keep in mind. Regardless of the pain condition, these three go together. And we have touched upon it already earlier about the biopsychosocial model. And that is something to think about. So when we talk about it, as we don't speak about it as either biological or psychological, but we incorporate it into this biopsychosocial model. I'm going to explain to you briefly this model, which is the fear avoidance model presented originally by Johan Fleyen, who was a professor in the Netherlands, who is now in Belgium. He presented the fear avoidance model, or rather the cognitive behavior fear avoidance model, in 1995. He had then identified that if you have an injury, it will lead to a painful experience. And if you have low levels of pain-related fear, that is catastrophizing or fear of movement, it will lead to that you more likely will confront with what you are supposed to do, and that will lead to increased functioning sooner. As opposed to if you have catastrophizing thoughts and fear of movement, which will lead to an avoidance behavior with disuse, disability, and depressed mood. This is the theoretical model that lies under the fear of injury and the catastrophizing thoughts. There are three different kind of concepts that are used synonymously, even though there are some differences between them. If you will be interested and you will go online and search, you will most likely now, this is the term most used. It's a broader term that incorporates fear of pain, fear of injury, fear of physical activity, and so forth. Whereas the fear of movement and kinesiophobia takes into the specific fear of movement. In 1995, there was one reference relating to fear of movement. It was a reference by Johan Flyen. If you go now and search just for fear of movement, you will find hundreds of references. And if you search for pain-related fear, you will find even more. So it's an area that has exploded, especially within physical therapy. And in the recent years, we have found a high occurrence of kinesiophobia in patients with fibromyalgia, chronic fatigue syndrome, arm, neck, and shoulder pain, complex regional pain syndrome, and most studies have been performed on persons with low back pain. If you look at fear of movement in the context of the orthopedic context, 70% of the patients who presented with low back pain at the orthopedic setting in Gothenburg presented with a high level of kinesiophobia. We could also not find a difference in fear of movement when we classified the patients as specific or non-specific low back pain. Men report a higher degree of fear of movement than do women, and we will not go into that, even though that is a very interesting discussion. There is no difference in terms of fear of movement in relation to overuse or disuse. I will come back to that. We have also brought the field of interest into the cardiac, through the coronary artery disease, and kinesiophobia has also proven to be prevalent among patients who had a heart condition. Even though they don't fear the pain, they fear to die. We will now go more into the pain-related fear in athletes. And Joanna Quist, who performed earlier today, was one of the first, or I think even she was the first in the world to relate the fear of re-injury in relation to sports and in ACL injuries. And these findings were recently supported by 2 systematic reviews in 2013 and 14. And the patients who did not return to their pre-injury level had then fear of injury. And the studies has kind of tried to dig deeper into that. So Annette Heine, who we did the Power for just recently, showed that in interviews that patients who had underwent rehabilitation after ACL surgery consider fear of movement a barrier of return to sports. And similar results were presented recently in an interview study in patients with ACL injuries. What has been touched upon earlier today as well is the relevance of identity for persons who are relate to themselves as athletes. Not being able to perform the sports that you kind of relate as part of your identity does not only makes it not possible to move as you used to, it also changes the way you think of yourself. And that is something I think all of you that are engaged in sports have come across. And the fear of losing identity is most likely strong in athletes, and it also has been identified as playing a role in the outcome of rehabilitation after injury. Niklas Olsson and his co-workers, that would be Karin Silbernegger and myself, found a negative correlation between kinesiophobia and functioning 12 weeks after an Achilles tendon rupture. And Karin Silbernagel also showed a negative correlation between kinesiophobia and heel rise work recovery at 5 years follow-up. In a paper in a study we performed in 2011, we had patients who came to us for suspicion of a chronic compartment syndrome, and they all performed different kinds of tests, physiological tests to verify their condition. And these patients have exercise-induced pain. And we compared them to a group of patients referred to as disusers, a group of patients with low back pain. And the reason for doing so is that in a discussion with the orthopedic surgeons, they usually refer to patients with low back pain as a certain kind of mankind. So as comparing these two groups, we could not find a difference between the groups, and they reported equally high degrees of kinesiophobia. And pain-related fear could be divided into affective and cognitive aspects. The fear is usually the affective component, and the catastrophizing thoughts are then referred to as the cognitive components. Usually, of course, these two go very closely together. What has been shown as very relevant is the catastrophizing thoughts has a high predictive value of the functioning. For instance, as this study is in, they did a study that was before surgery, before a knee arthroplasty. They could see the relevance of if you have catastrophizing thoughts, you have a poorer functioning 1 year after surgery as if you did not, indicating that we need to take the catastrophizing thoughts into the rehabilitation programs and at the prehabilitation stage more often as we had done until now. But now if we say that there are different kinds of, we could then say we have identified fear of movement, fear of re-injury, catastrophizing thoughts in patients with different kinds of conditions. Then how could we identify them? As we heard just in the talk recently, it's very important that you use reliable and valid measures. And for tools to use to identify abstract concepts such as catastrophizing, depressed mood, and pain-related fear, you use questionnaires. And then again, of course, what measure to choose? Of course, it depends on what are you interested in, what do you want to know. You have to identify that first. Am I interested in the catastrophizing thoughts? Then I pick an instrument for that is valid for the group that I'm interested in. And we have seen, we did a review in looking at all the measures available at that time to measure pain-related fear. And it's important when you pick the instrument that you pick one that is valid for the condition that you are measuring. That is, for instance, when we use the TSK for the tendon rupture patients, we could see that it isn't sensitive enough to pick up some of the lack of functioning or the fear, the attitudes that people that have ruptured tendons. So that we have to figure out something more specific. Then again, of course, as a clinician, you're interested in the responsiveness. How can I use these responses in clinical practice and see if there is a difference? If I want to target the fear of movement, how can I know there is a difference? There are two instruments that I have been especially interested in and I've used the most. They are the pain catastrophizing scale. It's designed by Mick Sullivan, who is a professor in psychology at Montreal. And it's Tampa scale for kinesiophobia, designed in Tampa by Corey in 1990. And those are different. Then again, that depends on how you want to use them. I would say that the catastrophizing thoughts, as you might recall, according to the model we looked at previously, that catastrophizing is the pre kind of factor before fear. So it's, if you're interested in before surgery, or you're interested in before a rehabilitation, I would look for the catastrophizing thoughts. As for Tampa scale for kinesiophobia, there has been a discussion how valid that instrument is, but that is the instrument that is most commonly used to patients that has like an identified fear of movement, or kinesiophobia rather. Cover that. And then if we have identified that people have fear of movement, kinesiophobia, and catastrophizing thoughts, what should we do? Is it enough just to say that this is the case? No, of course it's not. And the treatment principles that has been provided are by Stephen Linton, a professor in psychology from Örebro, Sweden, and Johan Flyen now in Leuven in Belgium. They base their treatment on cognitive exposure, in vivo treatment it's called. It's also, and they also refer to it, another thing, as graded activity. I would say that you would most likely recognize the principles in what they do, how you gradually build up your activities in relation to where the patient is in his or her return to play levels. The difference is to have a cognitive approach, and that is something different. I would suggest, if you're interested, there is a book provided by the IASP, who also defines the International Association for the Study on Pain. They have given this book, and it's written by Johan Flyen and co-workers. And they talk about the exposure-based treatment of chronic pain, but those principles could be applied to the athletes you meet. It's based on cognitive or operational principles, and it's based on extension of conditioning, so that you're relearning things again. And you kind of expose then the patient for tasks that they don't want to do, as for jumping down from a box after a tendon rupture, for instance. That would be very high on a fear scale for a patient that has ruptured a tendon. So you gradually build up your exposure, and not only like from physiological components, but for the psychological. So for the treatment principles and for recommendations is to identify psychological risk factors from the start, and not when the problem kind of starts to occur. I think that is one thing to keep in mind. By incorporating these factors into rehabilitation, you take them with you as you start, not when something goes wrong. By doing so, you are acknowledging that these are important factors for the patient. So when or if there will be more problem that you don't move further in the way you would like to do, you can go back and address these factors more easily. And by doing so, you might also want to know something more about the complexity of pain. It might be that you need to be updated on your pain knowledge. And I would say that you could optimize your treatment by adding these factors. It is not that you should do something completely different. You should optimize it. And there is a good amount of literature about the relevance of the placebo effect versus the nocebo effect. And by learning those principles, we could really be optimizing the treatment outcome. That's really what I believe strongly in. We published a study. I published a study together with Jo Nies, who is a professor in Belgium, about these principles applied in physical therapy. And the phase before you start is to have a pain neuroscience education, meaning that you explain what pain is to the patient in a dialogue with the patients. And then you try to the the goal is to extend the negative pain memories for the patient. And that is, you should try to decrease the anticipated threat value or threat level for the patient. And I think we as physios, or all healthcare providers, we are quite good in creating these kind of catastrophizing pictures for the patients, not even knowing it. Just the other day, I had a patient who came like totally devastated from the orthopedic surgeon. He has showed, yeah, it was a he had showed her a picture, like an X-ray, and he explained it like, yeah, there are 4 free kind of discs in, like, okay, kotor. Whatever. The vertebrae, they're kind of the free. They're 4, like, on the free levels, they're free. And she was totally devastated. And for him, it was a good thing. He meant there was nothing on the X-ray. But for the patient, she had the picture, the kind of the spine was totally going without any support in the back. And of course, it's much more fun to be a physio and talk about that like for orthopedic surgeons. But that goes with us as well. When we talk, what that makes and that what it creates, what kind of beliefs it creates for the patients. So I think we need to be more careful with what we say and how we say it. Yeah, and several articles, I just put up one here, but several articles also point out that patients are not the only one being afraid. Not all of us believe in that it's good to stay active while in pain. And that is something to be aware of. We all have prejudices, and we need to, the only way to approach them is to also be aware of them. And also to be sure, what do I need to know not to be able to perform this rehabilitation for this patient? And if I have doubts, the patient most likely will pick it up. You can't fool anyone by being more competent or more, I don't know. So going back to that, we need also as professionals to relearn. We are very good in the biological phase. We're starting to learn something about the psychology as well. And from the sociological part, I don't think we've gone there yet in terms of really incorporating it into the rehabilitation. Should we change? No, I don't think so. As I said before, we should add things to what we already do. One thing is to continue to support the self-efficacy, to make the patients believe that they can really do it. And that takes courage of us as well, because we have to step back. It's quite a good feeling to be the expert. That is also something to be like aware of. Of course it is. It's really good to say that you know something about what the pain system is or the pain physiology. But you know what? It's not sure the patients want to know all the details. Or maybe he or she doesn't want to know at all. So that is the start point. It might sound really silly or naive, but it is really what it's all about. What does the patient want to know? And I also think that we have even more to do, like if this is where the injury comes, like we'd heard before, in the pre-injury phase, what can we do? And as with all behavioral change, we need to change as well. And I tell you, that is even more hard than you even think, or at least that's my experience. So going back to Kajsa Bergqvist, she's my hero in many ways, and this is 10 months after she had her tendon, her ruptured Achilles tendon rupture, whatever, what it's called, whatever. Whatever. But I think we also have to change our perspective in being more active in preventing the attitudes and working with the attitudes and beliefs about being active with pain, and also to addressing this no pain, no gain. And one thing I would say that really I think would make a huge difference is if we are more active in community, to work preventive, not when the injury, only when the injury has occurred, but ahead of time. Working with parents' attitudes, working with trainers, working with the children. This is one of those who might be one of our athletes later on. What is her beliefs about pain? Pain behavior is learned, and it could be retrained. But we could also build a picture of what pain is kind of ahead of time. So add the psychological perspective from the start, not after. And let it run along as you progress during your rehabilitation. So incorporate the pain-related risk factors into the rehabilitation. And not to forget, the fear is a normal response to a threat. It's nothing strange. It's nothing psychiatric. It's a normal response. And identify your own attitudes and beliefs. And work preventive with both your own and with others as you meet. And thank you. And for those of you from Norway, Denmark, thank you.